Hello, welcome back to our course on Intercoronary Guidance in Complex PCI. We are excited now to move into a very interesting module of the course that is an interactive case discussion. We have with us Breda Hennessy and Enrique Gutierrez. And also we are fortunate to have online with us Dr. Ashok Seth from New Delhi, India. Ashok, it's so good to see you. Hello, good morning.
Good to see you, Javier, and thank you for having me.
Well, thank you, Ashok. We are going to hand, and most importantly, we have with us Nieves Gonzalo from Hospital Clínico San Carlos in Madrid, who is going to share with us one of a very interesting interactive case. Let me remind you, to all of you who are attending online, that you have a chat available at Wonder, where you can submit questions. We have Justin Davis is also a member of the panel, and he will be managing your comments and questions and putting them to Nieves and to the panel. Thank you.
Hello, good morning, and welcome to Hospital Clínico San Carlos. I'm going to share with you this interactive case. Our patient was 68 years old male with some risk factors, no significant past medical history, and the presentation was as a non-ST elevation myocardial infarction. He had progressive exertional angina over several months, but he had a very severe episode on the day of admission during exertion. When he arrived to the hospital, the ECG didn't show ischemic changes, but he had a mild elevation in troponin, so he was admitted and sent for a coronary angiogram. And as you can see here, this is the right coronary artery, where we can see this critical lesion in the proximal segment that was flow limiting. These are images from the left cistern, and as you can observe, there is disease also on the LAD, especially in the proximal part. There is also disease in the circumflex with this bifurcation lesion with several branches involved. These are some more images from the circ showing this lesion involving at least 3 marginals. The lab didn't show any relevant findings. The creatinine was normal, and in the echo he had a normal ventricle with normal size and systolic function, and no other findings. Valves were normal. This is the risk evaluation for this patient. The angiographic syntax score was 16, and when we calculated the syntax 2 score, it was equipoise for PCI or CABG. We also calculated his bleeding risk, and as you can see, he had a low bleeding risk by the precise DAPT score, and he didn't have any major or minor criteria in the HBR arc. So in summary, it's a 68-year-old male that presented with a non-STEMI. In the angiogram, he had this flow-limiting lesion in the RCA. He had a moderate to severe stenosis in the circ involving several branches, and this moderate by angiography stenosis in the proximal LAD with a lot of calcium, as you have observed. The left ventricle ejection fraction was preserved. The syntax score, as I mentioned, was equipoise for PCI or CABG, and he had a low bleeding risk. So based on these findings, the operators at the time decided to treat the culprit lesion. So they treated the RCA with 2 stents with good result, as you can observe here. And now we have a patient that had a non-STEMI and with 2 non-complete lesions. So maybe the first question here would be how to evaluate these non-complete lesions. We have had extensive discussion about the implications and what could be best to evaluate. So I would maybe now move this question to the panel. How would you evaluate these lesions? Would you proceed directly to PCI? Would you do physiology? Would you use OCT to assess the vulnerability of these lesions and decide on whether to treat or not?
Thank you very much, Nieves. So let's say, Ashok, you are with us. I'm sure that you will have some comments about this particular point, how to approach this particular revascularization. So I think that Ashok is with us.
Hello?
Yeah, hello, Ashok.
Yes, the slides are not coming on the full screen, so if your tech coordinator could actually bring them the presentation on the full screen. However, we were able to see these as small. Now that we've been told that it's moderate stenosis in the LAD and more severe in the circumflex, clearly we would want to measure physiology. That would be my first step in taking up this patient. And therefore, it would be an FFR down the LAD. And then, depending upon that, of course, I can't visually angiographically see the circumflex lesion, whether it requires FFR or not, but I would actually know whether the FFR is of the LAD, what that tells me, and then go down the circumflex to do an FFR. So that would be my present approach. It's more to do with physiology rather than anatomy at the moment.
Yeah, very good. Enrique, do you have any comment? What will be your comment at this particular point?
Well, I agree. I would really like to know the FFR of that proximal LAD. But most of all, I think if there was no severe ischemia going on at the time of catheterization, it would have been better to know the FFR of the LAD first, because maybe this patient could be surgical if there's a proximal LAD and all the other lesions. He could have gone to bypass. Of course, this is speaking afterwards, but it would have been interesting to know.
Yeah, I think so. I think that the point that you are making is very important. Nieves shared with us the syntax score too. That was similar in terms of recommendation. So I think that that's probably one of the main reasons, because it was the decision was made of going for also for percutaneous revascularization. You mentioned, Nieves, that the bleeding risk was small as well. Is that correct?
Yeah. Yeah, that's a very good point, Enrique. This is a 3-vessel disease patient, so the presentation was as a non-STEMI, so of course this could have been an option after doing the angiogram, deciding whether this is a patient for surgery or for PCI. But as you can see in the syntax score, the risk was equipoise for both techniques, so we thought this could be managed by PCI, and it's true that the lesion in the RCA was very critical. It was flow limiting, and the operators decided that they needed to treat this corporate lesion in the index procedure.
Very good. We are looking forward to seeing how you proceeded then based on this scenario.
So I'm going to skip these slides on the complete trial, because there have been a whole discussion about how to evaluate these non-corporate lesions and the influence that they have on the prognosis of the patients. So the procedural strategy here was, as you have mentioned, a physiological assessment of both lesions in the LAD and SHRI, then PCI to the physiological significant disease, intravascular imaging for optimization, and finally post-PCI physiological assessment. So this is the IFR in the LAD. We used IFR. In this case, you can see the pressure wire in the distal LAD, and this is the IFR result that you can see there, 0.73, 0.73. And as you can see here, is we are doing now a pullback. You can see me there performing a manual pullback of the pressure wire. You can see the recording of the pullback, and you will observe that we're going to have a jump in the pressure here in the proximal LAD. We're going now in the catheter. This is the pullback. What the next step would be is try to know where this focal step in the pressure is located, and for that we can co-registrate the IFR pullback with angiography, and this is what we're doing now. We are performing an angiogram, and after that you can see here the roadmap of the vessel drawn, and now after that we're going to have the co-registration of the angiographic and images with the IFR pullback. And as you can observe, most of the pressure loss indicated by these yellow dots is located in the very proximal LAD, actually proximal to these septal and diagonal branches that you can see. We can now even go a step further and try to assess what could be the result of treating this lesion. So if we could just implant a stent in the proximal LAD, around 19-20 millimeter stent, you can see that treating only this region, we could probably almost normalize the IFR value in the LAD. So this is the kind of physiological assessment that we do nowadays. First of all, you do a measurement that is going to tell you the functional impact of the global disease of the vessel, but of course it's important to understand what is the pattern of this disease, and for that we use the pullback. Then to plan the procedure and know exactly where these changes occur in the angiographic images, we have the co-registration with angiography, and finally we can predict the hemodynamic outcome of the interventions we're going to perform. So we have assessed the LAD, and my question now is, how would you evaluate the physiology in this LCX bifurcation? You can see that there are 4 branches there. To which one would you put your pressure wire? Which one would you evaluate? Which one do you think is the most relevant? Also thinking on the anatomy of the bifurcation, and how would you, which vessel would you like to stent if needed? Yeah,
that's very nice. News first of all, it was very nice to see how you predicted what was going to be the result of stenting the LAD. Let's come back with Ashok Seth in India.
Right.
And let me just ask you a much more broader question, Ashok. I guess that not many people are using, in a case like this, might be using physiology. Obviously, you have wide experience. You were already doing complex PCI before FFR was even developed. What is your reaction as to the way that we are proceeding nowadays in assessing physiology in this type of stenosis?
I think it's very relevant. Yes, we've been doing perhaps very complex lesions without physiology, but I think that's also showed us that we've overused stenting and relied less on aggressive medical therapy. I mean, that's what all the studies of physiology assessment have demonstrated to us. I think we've rationalized a lot now, and perhaps we are missing some very important lesions. So certainly in multi-vessel disease, I'm very clear that if we've got to appropriately use the therapies at our disposal, then physiology is one of the most important aspects to understand. The same thing which we do prior to the patient coming in cath lab or after a patient going out of the cath lab is what we should be doing in the cath lab and be making these decisions. So coming back to the case, that's interesting that the LAD has turned out to be significant lesion. And the circumflex, I'll address the circumflex because I think that's a great discussion as to where and how do you place that wire. But firstly, I also would like others to address this fact that the IFR turned out to be, say if the IFR was somewhere around 0.85, would you do an FFR in that situation? Would they just rely on IFR alone? Is there a discordance between FFR and IFFR in the intermediate scenarios? And what do we follow? That's a question which arises regularly when we can put our hat on a 0.73, but we somehow wonder what to do with an IFR of 0.85, of 0.82. So that's one of the aspects. And the other, in the circumflex, I'm clear that we have the first OM, which we perhaps are not going to intervene, but we have the second and a third bifurcation. And the second OM, the lesion extends into the second OM, but not beyond that into the circumflex. So I would be assessing an IFR down the second OM and then down the circumflex beyond the second OM and get my assessment of the lesions at that particular point, and then decide whether I want to stent from the circ into the second OM, which is probably what I'm going to do. And the circumflex beyond that would become my sidebar.
So Nieves, I think that Nieves is going to basically depict what you are
that's correct.
Suggesting.
Absolutely. And then I would go down the circumflex and do another IFR, and that would just perhaps
Very nice.
the,
Yeah,
the strategy
fantastic.
could be tending across that.
Very good. So, Nieves, can you comment also about the question of, or the comment of Ashok regarding FFR or IFR? Would you repeat FFR in this particular case, or you were happy with IFR?
Well, in this case, as you saw, the result was very positive. The IFR was 0.73, so I don't think there is much room for doubt, and we didn't do any FFR here. It was discussed a lot before in the session about the use of FFR or resting indices for the evaluation of non-complete lesion, which one could be better. In this case, I think the result was very clear, and there was no need to proceed to FFR.
But had it been 0.85, sorry, had it been 0.8 was my question, because I think this is a learning experience for everybody. What would have been the strategy then?
I think our strategy in general for non-complete lesion evaluation in ACS is using resting indices and using IFR, and I don't think we would have gone to perform FFR in this situation. We have seen previously in the talk how with FFR you can have some false negatives, with IFR you can have some false positives maybe. What is better, or what is the ideal balance? I think this is a question that is still to be answered. This is one of the things probably for future studies. But our strategy in general is keeping with IFR result. So Dr. Seth said that he would evaluate this second marginal and also the SHRI. So we can proceed maybe to see what we did here. And actually we did exactly what you were suggesting. So first you can see here the pressure wire on the SHRI, and you can see that again we got a very positive result, 0.60, the IFR at this level. Here we have now the pressure wire in the second marginal. And again, you can see a very positive result of 0.55. As you mentioned, the first marginal, we thought it was a small vessel, and we didn't evaluate it with pressure wire. And after obtaining this value, again, we performed here a pullback. We performed it from the vessel we thought we were going to stand, that is the second marginal. And you can see here a very clear focal jump at the level of the mid-LCX just before the bifurcation. We are approaching now the guiding catheter, and I will show you now the result of the co-registration with angiography. You can see here Javier is drawing the roadmap of the vessel, and after that we can obtain the co-registration of the IFR pullback and angiographic images. You can see how you can do this from the table yourself. This facilitates a lot the procedure, and you will see now in a moment the result of the co-registration, and it's very clear that all the dots are located in this lesion in the circumflex just before the bifurcation with the second marginal and the main circ. So I'm showing you here the results. So you can see the IFR towards the second marginal was 0.55, towards the circ was 0.60. You can see all the dots located there in the circ. So we also assess what would be the result of treating this lesion towards the second marginal. You can see that treating this part with a stent, we would probably normalize completely the IFR at the level of the second marginal. But the question now would be, how would you treat this circumflex bifurcation? Would you treat only with provisional one of the branches? Would you go for two-stent strategy? Which branches would you consider the main or side branches in this situation?
So, Prida, let me just put a question to you. Looking to this anatomy, can you point some of the key, say, objectives of PCI in this particular point? I mean, what will be your concerns, and what do you think that could be, what information do you think that we should gather at this particular point to ensure the safety and an optimal result of PCI?
Okay, well, I mean, you know, you've got a very significant bifurcation, so we have to make sure that we're going to get an optimal result. So I think, you know, if we can do a provisional strategy but check the side branches with physiology afterwards to ensure that we have an adequate physiology result, then that's a possibility. But I think we would have to consider also a two-stent strategy in this lesion. It's a very complex lesion, a large territory. So I think we could also image this as well to gain some more information, and obviously that would be important to optimize the result as well. So I think it's
So if I understand what you're suggesting, then Brita, will be that you will try to get as much information as possible
Yes.
to support, if possible, the use of a provisional stenting. Is
Yes.
that correct?
Yes.
Enrique, what would be your attitude?
Well, I actually agree. I think we've been talking about physiology in these two bifurcations, or almost trifurcation, and it's good to know which arteries are affected by the stenosis. But in reality, when I face this problem, what I want to avoid is vessel occlusion. So I would look at the angio and I would image. I would maybe do an OCT after ballooning to see if I need to use two stents. But the objective being avoiding the occlusion of the distal circumflex. Actually, if I can use one stent, I would use one stent.
Yeah, and I would add probably that, based on the results of complete and also the results of complete regarding the severity of stenosis, theoretically we know that in these patients, performing complete revascularization might improve outcomes. So in a way we are compelled of trying to do a proper revascularization, but at the same time keeping the safety of the procedure. So let's see what Nieves did from this point, because we're really looking forward.
So, Javier, can I just make a comment?
Please, anytime. Ashok.
Okay. So when I look at it, I say, okay, physiology is one of the aspects, but we've also learned a lot from anatomy, certainly for bifurcations. All our criteria of side branch protection, using two-stent strategy versus a provisional strategy, are based on many of the angiographic criteria which have been linked to outcomes. So when I look at a bifurcation, I analyze it in both ways. And clearly here, the disease does progress angiographically into the second OM, but not so much into the circumflex beyond the second OM. So I actually, therefore, am clear that provisional, with the true circumflex being my side branch and progressing the stent from the circumflex into the OM, into the second OM, primarily because I think the chances of occlusion of that second OM are far greater if I was to stent into the main circumflex, and if the stent, and we could always measure the FFR down the main circumflex following the stent to the OM and see whether it was provisional or whether we required to optimize it any further. So that's the way I look at it. The chance of creating an occlusion on a side branch is most to that OM2 rather than to the main circumflex.
Thank you. Very important comment, Ashok. So Nieves, it's your turn to show what's next.
So I think we were all on the same line of thinking here. And you can see here, first what we did was predilate this lesion. It was very tight, so we predilated with a small balloon. And immediately after, we went for imaging. In this case, we used IVUS. You can see the IVUS pullback here. This is the distal vessel that was pretty small. We have some disease already here before in the second OM. You can see a lot of plaque pattern at this point. And here we are reaching the proximal circumflex where the vessel is bigger and with a good area. Then more proximally in the circumflex, there was some disease also, but as you saw in the physiological co-registration, this was not functionally significant. If we move now, we can also perform a co-registration of the images with angiography and co-registration of the IVUS images with angiography. You can see here, this is the distal reference in the second marginal, that was our main vessel. as Dr. Seth was suggesting. And then we go proximal. This would be a good proximal landing area. We can also measure here from the table the size of the vessel at this point. You can see that this is going to be a vessel of around 3. You saw also here in the previous images how the distal reference, the vessel is around 2, so quite small vessel, and quite a lot of discordance between the size of the distal and proximal reference. So with these findings, you can see also how in the co-registration we can measure the distance between the references, and this of course give us an idea about the length of the stent we need to use. Based on that, we have a distal reference of around 2, we have a proximal reference of 3. We adjusted the size of our stent to the distal reference. We chose a 225 stent, 26 millimeters, in concordance with the findings from the co-registration of angiography and IBUS. So this is the implantation of the stent, as you can see here. We are now implanting this stent, and after that, of course, immediately we are performing a bot in the proximal part with a 3.0 non-compliant balloon. You can see here how we are adjusting the position of the balloon using also this enhancement of the angiographic images. This is the bot. And after that, we went again to evaluate the result by imaging. That's what we always do. In this case, we wanted to check very well distal edge because it's a small vessel. There's always problems, could be a problem of dissection, but we chose a healthy area, so this decreases a lot the risk of having a dissection. And we are now seeing that the stent is well opposed and expanded at all the levels. You can see that with the bot, we have adjusted the size of the stent to the proximal size of the vessel, and actually the result by IBUS looks pretty good in the marginal and circ. This is the proximal part of the circ that has also disease, as we saw before. So this is again the co-registration of the images. This is just the distal edge, and you can see here that there were no dissections at this level. And you will see also in a moment the size of the stent of the proximal part. You saw it on the images, how at the proximal level with the bot, the stent was well adjusted and to the size of the vessel. So this was the result by IBUS that looked very good, and this is the angiographic result. So of course now the question is, with this angiographic result, could you do something else in the branch? Are you happy and you just let it like this because it's not a big branch? What would be your strategy now with the branch?
Obviously a very relevant question at a point that we are seeing a lot of interest, great interest in the use of physiology to assess the results of PCI, in a way making the point that the uncertainty you have when analyzing an angiogram before PCI also applies immediately to the images that you obtain after PCI. So, Ashok, what would be your comment at this particular point? And then I'm very curious to know what Richard thinks.
So I think this is a good result. From from how I view it, the side branch after POT does not look very stenosed. You know, I tend to do FFRs down them if I really think it's 90%. Now the branch is large, there's no question around it, but it's not significantly obstructed. And as we know, there's enough data to tell us that the ones which are more than 75, less than 75% stenosed are usually FFR negative. So why try and go down that branch with an FFR wire? Of course, if you just wanted to show that it's FFR negative for the sake of people understanding and watching it, that's fine. But in the cath lab, I would just leave the procedure as it is. It's STEMI 3 flow. It's not more than 90% pinched. I'd be quite happy with that result.
Brilliant. What are your thoughts?
Well, I think, you know, angiographically we've got a very good result, but I think I think if it was me on the day in the cath lab, I probably would interrogate the side branch with physiology. I think that's something that we tend to do here quite a bit. So I think you can be surprised at times at the results of the physiology when you actually go to interrogate it. So that's probably what I would do.
So I think that tomorrow we are going to have a whole session on this particular topic of post-PCI physiology, etc. But let's have a look to what Nieves did.
So yeah, these are very good comments, and actually there was quite a lot of pinching on this side branch. It's true that many times this can be negative, but we wanted to check the result because it's a big branch, as you mentioned. There are two. There is still another marginal and also the circ there. So we wanted to check that the result was good. That it was not physiologically significant. So we decided to put a pressure wire, and as you can see here, we have now put it in the third marginal. Could be. It was not the same vessel where we put it before. Before we put it on the circ, and now the wire is in the second marginal because there was some disease also at this level. You can see how are we now trying to advance this wire. And is now coming in this second marginal, and you will now see the result. You're already seeing it there, but here I show you still image. This was the IFR in the jailed LCX branch. So actually very positive. You can see 0.38. So very positive result in this branch. So what would you do now with this jailed branch? With this positive IFR.
Enrique, you want to comment?
Yes, I would have never done it, actually. I mean, I try to make a point of not concerning myself with post-PCI physiology because it's always, for me, it's always complicated. And my objective would have been TME3 flow, so I would have let it stand. But now that you've seen it, well, I think I would balloon it and then do an IBUS and see what I can do.
Very good. So, Nieves, what did you do?
So in this case, yeah, as you mentioned, I think once you've seen this result, you are committed to obtain a good result in this big side branch. So what we did was actually, as you mentioned, we dilated it with a small balloon. You can see here the inflation. This is a 1.5 millimeter balloon. And it's interesting because you can see that we are doing it over the pressure wire. So you can see really the result of occluding the vessel, how the IFR is going really down. And you will now immediately see also how the IFR has improved just with this balloon dilation. We have gone from 0.38 to 0.66 just with this small balloon. So after that, we decided to go for a larger balloon. Sorry. So you can see here we're using now a 2.0 balloon. And again, you can see here during the inflation how we are including the vessel in the physiological physiology screen. And now we are deflating the balloon, we are pulling it out, and you can see how we have actually improved again the IFR in this branch that is now around 0.70. We, after that, tried to cross again with a 3.0 non-compliant balloon to perform the POD and to correct any deformation in the proximal part of the vessel that could have been created by this dilation of the side branch. And I just wanted to show you these images that we couldn't cross with used 3.0 non-compliant balloon. So even if you think that using a small balloon doesn't create a distortion of the stent, there can be some distortion of the stent, and actually we needed a new balloon to perform the POD. So this is the POD with a new 3.0 non-compliant balloon. And this is the result after this POD. You can see still that we have now a lot of pinching. So we dilated the branch, we improved the IFR in the branch. We then did a POD to correct the distortion that we have created in the main vessel. And it looks like we are just moving the carina from one side to the other. And as you can see here now, the branch looks quite pinched. The IFR in the branch is still 0.57. So what would you do now? Would you do something else here? Would you stop here? Is there any technique that could help you maybe to avoid this shifting of the carina? What would be your idea at this point?
So you know that a very important message for the colleagues is that in many occasions these pinched side branches that have stenosis that look very severe, when you look with, when you interrogate with a pressure guide wire, you actually find that they are not severe. But then you also have cases like this one, where irrespective that you are performing stepwise treatment of the bifurcation and the side branch, you know, performing POD, optimizing with larger balloon, etc., you still have a suboptimal physiological result, perhaps because you have a lot of recoil at the point of the ostium, etc. So I think that this is really, really interesting. Ashok, what would you do at this particular point, and what is your reaction to what has been done so far?
So my reaction to what's been done so far is how you keep falling into the trap of overdoing physiology in a side branch where the consequences, you must remember, the FAME 2 did not ever look at side branches, and certainly not side branches which were covered by a stent. This is a whole new area, and we tend to correlate atherosclerotic plaque and its outcomes with a jailed side branch which has got metal across it, and believe that it's going to have the same outcomes, same event rates, and same symptomatic status as an atherosclerotic plaque sitting in a vessel. So we tend to keep on changing FFR in physiology without correlating to outcomes which have never been shown as far as diagonal is concerned, or side branches are concerned. All we know is they can be normal even if it's 75% stenosed, or they can be abnormal even if it is looking less stenosed. Now, we've gone now into dilating that branch. We still haven't achieved a good FFR. Your next step would be, the only thing which has been done is a side POT, side POT. But we also know by bench testing that POT side POT does lead to, again, repinching and shift of carina into the side branch. And I would actually, if it was to be done, then I would still avoid a second stent into this 2mm side branch. I would actually do a kissing and then a POT, because that's the best way to keep the carina central. That may be the best way to get the maximum physiology, and I would not aim for an IFR of 0.9 in this vessel. I'd be quite happy to just achieve whatever I could without destroying our main vessel, and I'd be just happy with that result. I would avoid a second stent, because that's just for angiographic appearance, but that's 2-stent strategy in a small vessel with a 2mm side branch is not the best thing which I can think of.
Thank you. Very, very sensible point. We will come later to your comment of, the information we have from the FAME study and the contemporary thing and the contemporary knowledge. But let's move now with Justin Davis. He's managing the comments from all the colleagues that are attending the meeting. Justin, do we have any comments? Or?
We have a question. I think it's regarding one of the angio-FFR-based techniques, and from Dr. Jorgensen, who says, could this patient potentially be a favor 3 patient? So I think he's looking at using more of a non-invasive guidance technique to re-guide revascularization. I think that's the basis of the question.
Favor 3, but the only problem with QFR, that would be my comment, I don't know if there are any comments, is that for the time being, the use of QFR in bifurcations is quite tricky, particularly if the bifurcation is a relevant one. And actually, in Favor 3, a bifurcation with a large vessel is actually an exclusion criteria. So it is true that QFR, an angiography-based technique, geography-based approach, is a very promising technique. But there are a number of scenarios where it is very challenging, including ostial stenosis, for example, aorto-ostial stenosis, left main stenosis, and as I say, any bifurcation lesion. So Nieves, back to you, and I'm sure that you will be taking into consideration the comments of Ashok.
Yeah, I think we were exactly in the same line of thinking. So that's what we did. We did a kissing because we really didn't want to implant a stent in this branch. And as you can see here, we did a kissing with 2 balloons, 2.0 and 2.5, at 2 atmospheres, 12 atmospheres. This is the enhanced image again, using angiography of the kissing. And well, we were quite happy actually when we saw the physiology after kissing, 0.80. I would definitely accept that in that side branch Dr. Seth was suggesting. But unfortunately, when we did an angiogram, that's what we saw. So yeah, we have definitely improved the vessel, the ostium, but now we have dissections. And maybe it's interesting if we go back, that I can show you that there is actually a problem in this side branch, not only at the level where the vessel is pinched, but also there is another lesion in this branch. You remember that when at the beginning we put the wire in this branch, in the circ, and now we are with the wire in this other branch, like the 3rd marginal. It has another lesion here, and I think that was the problem here, that probably the kissing balloon went into this lesion, and probably that created, it was maybe a bit too long, the balloon, we went into this lesion, and this created the dissection. But that's exactly what you were suggesting, Dr. Seth, about the problems of treating these small branches. You can have situations like this, where now you have a dissection, and I don't think we have many options now, apart from fixing that. Definitely the angiographic, the physiological result would have been acceptable, but I don't think the angiographic result is acceptable at this point with this dissection. But I would like to hear also your comments. What would you do now? Would you still decide that you don't want to put a stent here, or would you go for a stenting?
So that's very important. Perhaps something that we should state is that we never consider this as a small branch. So all the discussion that we are making is that we thought that this is actually a quite sizable or large side branch that should be protected. Certainly, this probably will not have been done if the vessel side branch would be 1.5 millimeters in diameter or something.
Yeah, it's definitely a significant territory, because actually there are 2 branches there, the circ and the marginal, but the size of the vessel is a bit limited, and that's the reasoning why all the time we were trying to treat it with balloon and avoid a stent. But what would be your option now?
Enrique, what would be your attitude now?
Well, now you have to stand clearly. I would be concerned about a 2-stent technique, because you've already had trouble just passing a balloon after dilating, and so maybe I would try to leave a stent there as a tap or a T, and if it doesn't go down, well, you can anchor and use a guideliner or something like that to avoid all the friction in the proximal pad. But yeah, now you have to stent it.
Ashok, do you agree?
Yeah, I agree that it has to be stented. It's only a small vessel in terms of diameter, but it's a large territory in terms of distribution, and therefore we have no option but to stent it. I was just going to say one comment. I think this actually tells us my first statement. In a side branch, I'm reluctant to chase physiology because of the complexities of going into a side branch, because of the very situations of crossing, recrossing, destruction, creating problems of the main branch, then going to the side branch, occasional dissection, occasional two-stent strategy. And then if you look backwards, and of course, we've all got the benefit of retrospection in such a case, but it also teaches us that perhaps leaving a side branch which had low IFR may not have been such a bad idea than to have a two-stent strategy on small-sized vessels, which is what we are ending up with, because the side branch could close off, has the highest chances of closing off following a two-stent, finishing off with two-stent. So whether 0.37 was better than a second stent in that side branch is just the open question that we all have to answer.
Yeah, I'm very curious also to see Nieves' point of view. Personally, what I believe is that we are striving to optimize our interventions aligned in the same direction that we started an intervention from the very beginning, that is improving the flow conductance of the vessel, improving the hemodynamics. And as we will be discussing in this course, there is an emerging number of studies demonstrating that actually you may finalize your procedure leaving behind flow limiting stenosis, that that probably this accounts for the reason that in about 30% of patients that you treat for treating symptoms, they continue having angina at 1 year. So there is a lot of room for improvement in the way that we perform PCI to control angina. And the final thing that I would like to discuss about this point is that the intention of this course is to share with the colleagues a number of skill sets of skills that actually you may have in handling different scenarios. And I believe that it is very good that everyone knows how to perform POT or to perform DK crush, but it is also very, very good that anyone who is embarking in treating a bifurcation is capable of using physiology and imaging to guide decisions. This is something that is really, really important. It's not just only placing the stents beautifully, it's making sure that you do it at the right time and that you do it in the right manner. But over to Nieves, I'm sure that she will be commenting on this and many other things.
Yeah, I mean, this is kind of a trifurcation. There are 3 branches. We are just stenting one, and we thought in this case we really needed to check the result towards the other 2 branches that were not treated. And I think once you've done an IFR there and you have 0.3, I mean, you are committed to improve the result at this level. Our idea was trying to do that with just ballooning and trying to avoid a stent if possible. But you have seen that we have followed a stepwise approach here. And now we are in this situation where we have this dissection. This is something that can happen, especially if the vessel has disease, as you can see in this third marginal. So we now are committed to treat this dissection with the stenting. And that's what we did. And as Enrique was suggesting, we decided to do it with the tap. You can see here, this is a 225 stent by 50 millimeters in the side branch to cover also this lesion and cover properly the dissections. We have a 3.0 and C in the main vessel at the same time. You can see here in the stent boost how we are using it to adjust the position of the stent and do a proper tap. So this is the implantation, inflating also the balloon in the main vessel. We're going now down with the balloons, and now we are moving the balloon from the stent in the side branch a bit more proximal to do a kissing. And this is, you can see in the stent boost, the result of the tap. That looks actually quite okay. We have created this small neocorina, but the result looked good by a stent boost. And you can also see now the result here in angiography. And you can see also the physiological result. As you can see, we had all the time, we did all the procedure through the Barata wire connected, and you can actually see very nicely the physiological result of the interventions you do. So yeah, now this is the final result that was good by both angiography and physiology. So I think this was a final good result for this bifurcation. Any more comments from your side?
I just say that I think sorry.
Carlos, go ahead.
Go ahead.
Okay, I was just saying, tremendous. I think it's a very illustrative case. I think you did it beautifully. Yes, you're right. And we could have made those decisions. We could have actually, the dissections do happen as a side branch. But the way you've actually used both anatomy and physiology, both to guide the end result, which is perfect. I think this patient's really going to be asymptomatic. So I take that point. Perhaps this result, at least in terms of symptoms, could be better than leaving the side branch with a low FFR or IFR. We don't know the long-term outcomes, but I think this is a very satisfying experience done very scientifically to achieve the best possible result in the cath lab. Very, very, a great learning experience, I'd say.
Did you perform something else in the case, Nieves?
Yeah, so then we move to the LAD. If you don't have any more comments to the CERC, now we have some work to do in the LAD.
Yes, yeah, we forgot about that.
So let's go to the LAD, which is also interesting because you saw that it's quite proximal and it's very calcified. So this is also an interesting lesion to assess. First thing we did here was imaging, which is very relevant because of two aspects: the calcification and also the distribution of the plaque. Where can we land our stent safely, especially in the proximal part? You can see that there is some disease in the mid LAD after actually the diagonal, but what is interesting in the proximal part, you can see a lot of calcium. You have seen it there. There are some areas where the calcium is almost circular. This is the ostial LAD. I will show you some still images later on to clarify this point. But basically, these two aspects, the calcification, very severe, with calcium ring really at the level of the proximal LAD. And these are the most interesting parts of the pullback. First of all, I want to show you the ostial LAD. This was a concern for us in this case because the lesion was very proximal. We didn't know whether there could be a good reference area in the ostial LAD, or we would need to go into the left main to find a good reference. But you can see that there is actually a calcified nodule at the level of the ostial LAD, but the area of the lumen at this level is quite big. It was 9.2, and actually the area of the lumen at this level was very big, 2.7 by 3.9. This is just the bifurcation. You can see very well bifurcation of the LAD and the CERC. You can see very well the calcified nodule here. You can see also how the calcified nodule extends a bit into the distal left main, but again, this level, the area is very good, and this is the mid left main that looks much healthier. So I have two kind of questions for you now. The first, where would you land your stent proximally, and what type of plaque preparation would you choose for this case? I would like to hear your comments.
Let's start by the second, because we have Brita is, in the course is going to speak about role of imaging in the management of calcific stenosis. Well, Angela McKinley, sorry. So Brita, would you like to comment about this particular topic? What would you do?
So I think the nodule of calcium is quite eccentric, so I think we need to take that into account. So I think this possibly is a good case for lithotripsy. I think shockwave could be useful in this case, just to get an optimal result. So I think that's something to consider here.
Ashok, what would be your plaque preparation strategy in this particular?
I didn't see the imaging at the site of the lesion, though I saw it in the ostial area. So I didn't get an sense of the size of the LAD at the tightest point of the lesion. What was the size of that LAD?
It's big. It's at the level of the ostium was around 3.5, and also the distal could have a 3.5. These are the references here.
Okay.
These are the references.
Yeah.
In the mid LED is 3.5. It's a big vessel.
If it's a big vessel, I would go, and it's, by the way, it's not for the nodule, it's for the calcification at the site, which is what I would go for an IVL. I perhaps may actually do a rota as well as IVL, a rotatripsy, for two reasons. At the ostia, I perhaps would eccentrically burr across the nodule, which will make my implantation of stent easier subsequently. We know lithotripsy IVLs fairly poor for these nodules, and we don't want to come up to the ostia. We certainly want to come close to the ostia, but certainly not cover the ostia. You don't want to come into the left main either. So I'd probably just burr across the ostia into the LAD, and then use a lithotripsy for the tightest point of the lesion, and then implant a stent after I've done an imaging prior to implantation of the stent. So that would be my philosophy. The reason for that is also that if there's a lot of eccentric calcification, I believe the rotational atherectomy, burring by rotational atherectomy, gets the balloon closer to the deep calcification for it to work more effectively. If you're in an eccentric calcification and you're away from it, it perhaps is less, or you have to give a lot more pulses. So in both those instances, I prefer a rotatripsy, and that's what I would do in this patient.
Very good. So, Nieves, would you show us what came next?
So maybe we can go back to the IVUS pullback for a minute to discuss about the calcium strategy that we chose. And as you can see, you were talking about eccentric calcium or circular calcium. You can see these are images from the IVUS pullback in the mid LED. This is corresponding to this yellow dot that you can see here. And actually at this level, the calcium was quite concentric. It was almost a ring of calcium. So points more than 270 degrees. I mean, and at certain frames, we saw a complete ring. And actually, the calcified nodule was located more proximal in the ostial LAD. That was actually the region that was going to be our landing. And there's a calcified nodule here, but the luminal area at this level is very big. So we thought that we didn't really need to treat the calcified nodule, that we were just going to implant the stent at this level. And actually, this is the proximal reference we chose to land our stent at this level. This is the distal reference that we have seen. So based on that, concentric calcification, and no need to treat this calcified nodule, we chose in this case IVL lithotripsy, as you mentioned. And you can see here these images. This is a shockwave balloon 3.5. You can see here already in this enhanced image of the balloon how difficult it is for the balloon to expand, but you will see very soon the effect of lithotripsy and how the balloon starts to expand once we start with the pulses. So Javier is there going to 4 atmospheres. This is the usual technique with lithotripsy. I'm applying here the pulses, and you can see immediately how the balloon starts to inflate better after the pulses. You can see actually maybe the bubbles inside the balloon, which is the mechanism why lithotripsy works, creating these bubbles that then explode and create this very high pressure milliseconds that goes into the plaque and breaks the calcium. This is, we are here applying more pulses. And you can see how the balloon looks better now. Still a bit of under expansion at some points. So we continued applying pulses. And when we were satisfied with the expansion of the balloon, then this is the final inflation of the balloon we achieved after all the lithotripsy shocks we gave. I think we gave 40 pulses. After that, we proceeded directly to stenting. And based on the references I've shown you before, we chose a 3.5 by 18 millimeters DES. You can see here we are positioning now the stent. We wanted to be very precise with this proximal position because we wanted to be close to the ostium in this area where we had this good luminal area without really getting into the left main, without jailing the circ. So we are using here rotational angiography to try to adjust the stent properly in different angulations. And we were happy with that position, and we are now implanting the stent at this level. As I said, this is a 3.5 millimeter stent. You can see that there is actually still some under-expansion. You can see the stent boost here on this image, demonstrating that actually even after all the preparation, there is still some under-expansion of the stent at this level. So we performed post-dilation. This is a 3.5 non-compliant balloon to try to compensate with this under-expansion, and you can see here a very good result. You can see here the vessel, the balloon is opening well, and we have corrected most of the under-expansion that we saw with the initial stent implantation. This is IBUS afterwards to check the result. And as you can see in the LED, there is a plaque that is more distal, and we decided not to treat because it was not significant from the functional point of view. Here we start with our stent that looks good, well apposed and expanded. This is the region with a lot of calcium. You can see more eccentric shape of the stent at this level, but the area looks good. We will measure it in a while. And we have really put it where we wanted, so we have not touched this ostial LED. We have not jailed the circ. I'm showing you here some representative images of the IBUS pullback. You can see the distal part of the stent that looks good, adjusted to the size of the vessel. This was a minimal stent area that was 6.2 millimeters, and actually it was more than 80% as compared with the references. So good expansion by the criteria we normally use to assess the expansion. And this is the ostial LED. This is where we had this calcified nodule, and this is just a bifurcation. So we have put the stent just distal to the bifurcation as we were planning. So this is the final angiographic result. You can see good result of the stent. You can also see this stenosis distal to the septal that we didn't treat because it was not significant from the functional point of view. You can also see that there is a very significant milking of the vessel in the mid-LED. And so the result angiographically looks nice, but we of course wanted also to check the physiological, the functional result, whether we have achieved what we were aiming for. And this is the IFR post in the LED. You can see 0.95, so a good result after implanting this stent in the proximal LED and optimizing it. So this is the final result. I don't know if you have any more comments or...
Enrique, do you have any comments on the case and the way that we proceeded with it?
I think it's a great result, and I think overall the whole case is a great case. I mean, I disagreed about doing the IFR and making a decision based on the IFR on the distal circ, but that doesn't mean that I'm right. I mean, you did it and it's fine. And then there was a lot of trouble in the circ, and I think it was very well managed at its step, and it's a great case. It's a really great case.
Ashok, any comments from your side?
No, I think the LED has been done beautifully. I think it's been done very physiologically. You've avoided putting in a long stent in an area which was not significant. You've proven it at the end that you actually did limited stenting of that LED in the most complex area and the most diseased area. Again, you know, it's often, I think, yes, we do rely on lithotripsy quite a lot in these concentric, and I think in eccentric lesions, that's where I use a lot more rotatripsy, and I do a fair amount of rotatripsy just for the sake of getting the balloon closer to the medial calcification. Great result. I thought it's been brilliantly done. I think it's in great teaching experience. We're learning it.
Brita, what was your impression about this case and in general when you see cases like this performed with the guidance of intracoronary imaging and physiology as as a fellow in interventional cardiology, what is your reaction, and when you speak with colleagues in other centers, what do you discuss about this particular topic?
So I think this case is a beautiful demonstration of really the importance of using physiology. Certainly I'm perhaps biased, but I think the physiology here proved to be very important in certainly the circumflex bifurcation. I think, again, this case shows us the importance of using imaging, be that, IVUS or OCT, but the point is to use it. And I think it's very, very beneficial. I think it's underused in certain centres, but I think the point is that, as a fellow learning, I think you need to really embrace these techniques, and I think you get better results, and it's certainly safer for the patient. So I think it's important to use them.
And probably, from the perspective of the curriculum of the fellows, having the possibility of benchmarking the result of interventions, through physiology and imaging, will probably raise the standard even more in terms of achieving good results. What is your impression, Ashok and Nieves? What about the educational value also of checking the results of your intervention with these techniques?
Yeah, you're so right, Javier, and I think that's what is most important to comment. Long-standing operators who've actually gone through balloon angioplasty to stent era, and you remember the bare metal stent era was all about optimization. That's how intravascular ultrasound proved that if you gave yourself the largest lumen, you actually had the best long-term results, and you decreased stent thrombosis, and you decreased the possibility of restenosis. That was in the bare metal days, and we started optimizing stents. So we learned to do high pressure implantations much earlier. Well, the drug-eluting stent era made people less conscientious about achieving optimal results, because they felt that the restenosis has been conquered by just suboptimal implantations. Therefore, for the new entrants into this whole interventional cardiology field, the only way they can actually optimize, we know that in most instances, our eyes can optimize results because we go for larger lumens, we always go for post-dilatations and so on. And so therefore, we are less surprised at the imaging findings and physiological findings, but it's so important to be able to correlate the final angiographic result, which is usually, when assessed by imaging, usually very poor. What looks like a great angiographic result is usually, in 50% of the times, poor when looked by imaging and needs optimization for the new entrants. And therefore, to place that as a benchmark becomes very important to give the best to the patients. I think that can only happen by imaging. Imaging and physiology are the best that you can do for your patients. And I do believe that 15 minutes of extra time that you spend with a patient to do imaging and physiology may actually give the patient an extra 15 years of a lifetime in terms of outcomes. And that's what we owe to our patients. 15 minutes for 15 years. If we can't do that, then we've been unfair to our patients. So I think it's very important, and young generation should always understand and optimize their results and start getting the hang of how bad angiography is and how good imaging can be for the patient outcomes.
I think it's a very good result, and perhaps, Ashok, at this point, now that you were going back in time, perhaps we should disclose to our friends and colleagues attending that 30 years ago, or 30 years plus, we were both residents in the UK, and that you were a senior resident to me, and that I performed my first coronary angiogram under your supervision. So,
and I must say, I taught you the angiogram, but you've taught me physiology and imaging, and I think that's the other way around.
But it's very good to hear now your comments about angiography 30 years down the line. Anyway, so we over to Nieves for the last comments. I think it was thank you very much for this beautiful presentation, Nieves. Everything was so illustrated with so much in detail. But perhaps you can give us a final message on what you learned in your case.
Yeah, I think it was a challenging bifurcation. We saw that from the beginning in the circ. We tried to manage it in the best possible way. We tried to keep with provisional. We really tried hard to keep with provisional. Try to avoid extending the side branch. There was a vessel that was not very big, but a large territory. We knew that we needed to optimize the functional result in this territory, and in the end, the result was good. I think the idea always with provisional is that you are always your options open, so you can go stepwise and optimize if you don't get an optimal result. And in the end, in this case, we needed to use a second stent, and the result was good. And in the LED, this very calcified lesion, the use of these new tools that are very helpful, like lithotripsy, I think it helped us a lot in this case. Otherwise, we could have probably suffered quite a lot with this calcium brim. There are all the techniques like rotational atherectomy, etc. But I think lithotripsy facilitated a lot here. And about the use of physiology and imaging, it's very interesting what you were saying. Actually, I think everyone that does imaging knows that angiography is very misleading. You can see sometimes a very good result by angiography, and then you have a very extreme underexpansion, focal underexpansion that is not visible by angiography. So the use of imaging to always optimize. And if you're going to use imaging, why don't you use it from the beginning? Because this will provide you with a lot of information on the plaque characteristics, the sizing of your vessels. You don't need to guess. You have your measurements there. You can do really precise PCI, and I think that's the way to go in the future.
Thank you very much again, Nieves, for preparing this case in this great educational manner. Thank you very much to Ashok, Brita, to Enrique also for being serving as panelists and commentators. Thank you very much to all of you that have been engaging with the case through the platform at Wonder, and thank you very much to Justin for managing the questions from all of you. So we will close now this interactive live case. We keep you keep in touch, because in a few minutes we will start another block of sessions of our course, in this time dedicated to two very interesting lectures on intracoronary imaging and physiology. So stay with us. We'll be back in a couple of minutes. Thank you.